is Krebs. I'm an emergency medicine physician and a global health fellow. I know a lot of you in here. For those of you that I don't know, if you want to know more about this, feel free to catch me afterwards or have my email address up and so on. So I'm doing a global health fellowship here at Duke, but what I'm going to talk about today is something I've been working on collaboratively with some other people for the past couple of years, trying to design a program to teach physicians in Rwanda to use ultrasound. So we formed ourselves into a little organization that we call PURE, the Physicians Ultrasound in Rwanda Education Initiative. So I titled my talk From an Idea to Execution to try and get kind of a sort of general overview of all the different steps that we went through to get to where we're at today. So I'm going to go through a little bit of background, history of Rwanda, some pictures, so on, my personal history there, talk about ultrasound in particular and why we think it's such a great utility in the context of Rwanda, talk about our program and organizational development process a little bit, talk about the program that we just launched at the beginning of this month, and then future plans. And I really want this talk to be informal, so if you have any questions about anything, please feel free to stop me. I don't think I could take up a whole hour going through my slides one by one anyway. So this is Rwanda. It is a tiny little landlocked country in East Africa, bordered by the Democratic Republic of the Congo, Uganda, Tanzania, and Burundi. But it has 11 million people in it. I've heard people mention that it's like the size of Maryland, give or take, on the scale of the states. It's a really beautiful country. I have a few photos to kind of show it off, but lots of rolling hills. It's called the Land of 1,000 Hills. They're well known for their gorilla population that lives up in the Virunga Mountains, and they've done a really great job of capitalizing on this tourism opportunity, little city scene. And this is a scene taken from the Gisozi Genocide Memorial in Rwanda. It's just a scene of Kigali, the capital city there. And unfortunately, Rwanda is still probably best known for the 1994 genocide of the Tutsis. This is a topic that people write full books on, multiple lectures could be given. It's really interesting, but I'm not going to get into it too much here. In general, in Rwanda, there are two majority ethnic groups, Hutus and Tutsis. In 1994, from April to July, estimates from between 800,000 to 1 million Tutsis were killed in the genocide. And since then, over the past 18 years, the country's been working through reconciliation and rebuilding from that, as well as just general elimination of poverty. But these are both from genocide memorials around the country. Purple is kind of a national color of remembrance of the genocide, and then those are some names of people who were killed in the genocide. So I got to first experience Rwanda in spring of 2009 when I went as a fourth-year medical student, and I had an amazing time. I got to spend some time in the university hospital in Butare, Rwanda, and then I got to spend some time also up in rural Rwanda trying to help a grassroots development organization as part of my medical school identify a village, a new village, to start working in. Especially within the hospital and the healthcare system, I just had a lot of really great experiences and learned so much. These pictures in particular are of an intensive care unit bed in that hospital. There's an incubator with 3 little premature babies in it, and then they are performing surgery down in that bottom left-hand corner, doing an open cholecystectomy, which is kind of their standard procedure for that in Rwanda, whereas here we're doing more minimally invasive surgery for something like that, and it just sort of illustrates the differences. And importantly, in the bottom right-hand corner are some of the friends that I made during this time here, and at the time they were physicians in training like myself, and now they're doctors as well. But we've maintained really good contact, and they've been really instrumental in kind of helping direct my future paths for continuing trying to work in Rwanda. So in terms of PURE and ultrasound training in Rwanda, it all ultimately spun from my initial experience in Rwanda, just falling in love with the country, basically, and wanting to go back there as a resident. I had an elective time coming up, and so I wanted to try and come up with something a little bit more meaningful to do than just kind of spend some time within the hospital again. It's something I've done as a medical student, and I wanted to try and be able to actually contribute something. So I just got on Google, and I ended up finding out about this organization called Assist International. And what they were doing was dispersing donated ultrasound machines from GE around Rwanda to the district hospital systems. So I talked to some of my friends and said, hey, have you guys seen these machines? What do you think of this? They're like, yeah, I mean, they're great. They don't do a lot right now because no one really knows how to use them. They're in the district hospitals, but the radiologists and technologists are not in the district hospitals. And we just really don't know how to use them right now, so they're not getting a whole lot of use. And that's kind of where this idea started to come from. As part of emergency medicine training, you learn to do point of care at the bedside ultrasound in helping to care for your patients. And in my own training, I was starting to really appreciate ultrasound as a utility. So at the time of all of this occurring, I managed to connect with some fantastic people who have worlds more experience in ultrasound international work than I do. And they really kind of helped guide the development of everything with Pure, and now make up the main body of those of us working with Pure. But a little bit about ultrasound in particular. It's really fantastic technology for a number of different things. As an imaging modality, it's really versatile. You can image all kinds of different things. You can see them dynamically. The way it works is an ultrasound probe emits some sound waves. It goes down through the tissues and bounces back to the probe. Depending on how fast it gets back to the probe, depending on the type of tissue it went through or was reflected from, generates the image on the screen. So you just see everything in real time. Additionally, the way of obtaining these images doesn't deliver any ionizing radiation, which is something we in the medical community are becoming more and more aware of, as that's more associated with CAT scans and x-rays and so on. So it's a really great tool. Additionally, as part of emergency medicine, there have been some studies done that have shown that physicians who learn to use point-of-care ultrasound can really use it well. They can use it and obtain images accurately, they can learn it fairly easily, and ultimately it can improve patient outcomes in a number of different clinical settings. There have also been some studies to show that ultrasound has value in a developing world, resource-limited setting. There's really nothing out there right now to correlate it with like a mortality or morbidity benefit, but there's a lot of stuff that's showing that it's changed the clinician's management decisions based on the images that they've obtained. So Rwanda would certainly be considered a resource-limited setting. Some statistics: in 2009, they had about one physician for every 15,000 people. They've made fantastic strides towards achievement of the Millennium Development Goals, but their maternal and infant mortality is still high. And importantly, in the context of ultrasound, there's only 6 trained radiologists in the entire country, and they're really all concentrated in the main city. The district hospitals are arguably where they feel the biggest impact of these limited resources. The way the healthcare system is set up in Rwanda is that the community health center, which is kind of like a clinic staffed by nurses typically, is the first entry point into healthcare for patients. If they find there that the patient has a problem that they can't handle, they're transferred up to the district hospital level. And here they have some utilities to help care for them. And if they can't handle it, then they can send them up to the referral level hospital. But these district hospitals really vary in terms of what they can handle and their patient loads and their resources available to them. Generally, anywhere from 10 to 18 physicians will staff these hospitals, and we found that some of them have a catchment area of patients that could come in of as many as 600,000 people, and this will be a population for 200 to 400 hospital beds, and these 10 to 18 physicians will care for all the admitted patients as well as see them in the outpatient and the emergency department as well. Resources are fairly limited, especially in terms of diagnostic imaging. There are a few people you'll find here and there with some specialized obstetrical ultrasound training, but usually nothing further than that. And diagnostic capacity in general is just quite low. Ultrasound in particular, kind of reiterating some other points I made, there's very limited training in medical school. Specifically, they have a 2-week-long radiology rotation during which they spend maybe 4 hours doing ultrasound, and that usually involves a group of medical students standing around a preceptor performing the ultrasound and just kind of observing that way. There are even less technicians or ultrasound technologists in Rwanda than there are radiologists. There's no training available. You have to go South Africa or Uganda are the 2 places that I've commonly heard from people. And many of these district hospitals have a machine. Many are varying quality, but most are functional from donations. And then within the past year, the Ministry of Health made a purchase of 30 brand new ultrasound machines as well. In general, too, the acuity and variety of the disease burden that these physicians in Rwanda's district hospitals are responsible for, it really could benefit from having ultrasound in the diagnostic. So these are a couple pictures that I took when I was in Rwanda doing my elective rotation. And I was kind of just trying to illustrate to the people I was working with some of the different variety of uses for ultrasound, because there's so much emphasis on it only in obstetrical care.
Where the lights go? So I can see the pictures?
Sure.
Sure, do you mind just look at the switch? It's oh, fire.
So up on the left is a picture of the inferior vena cava, the big blood vessel, the big vein running down the middle of your body. And the significance of that is that when you breathe, the size of it can vary. And if you don't have enough fluid in your blood vessel there, whether from dehydration or blood loss or whatever, it will close almost completely, as you can see there. And so you can use that as an assessment of whether or not they're absolutely resuscitated. Otherwise, up in the left-hand corner is the spleen, and then a heart. Nothing particularly pathological about them there. So we at Pure kind of took all of this stuff together, all of the different things that we knew about Rwanda and what we knew of ultrasound, and we tried to create an idea for a program based on the constraints of the healthcare system, based on the interest that we had found in learning ultrasound amongst physicians, and then based on what limited training they already had. We did some literature reviews. We talked to other people that had done similar programs, and we just kind of tried to think about things contextually with what we knew of Rwanda. And based on that, we hypothesized that if we can do training well, and ultimately enhance the diagnostic capacity of these district hospitals by providing ultrasound through point-of-care ultrasound performed by physicians, we could decrease transfers to outside hospitals for other imaging tests, we could decrease hospital lengths of stay, we could decrease healthcare costs, and we could improve clinical outcomes ultimately. Additionally, we read some articles that were talking about the different factors that tend to come into physicians' rating of their job satisfaction level and the reasons that they leave their current position. And something that was highly identified was educational opportunities and a better ability to provide high-quality care for their patients. So we hope that with this extra training and these extra skills, they could find more satisfaction in their jobs. And something specific to Rwanda is this concept of continuing professional development, or CPD, which is basically the same as our continuing medical education emphasis that we have here. They set up a system. Within the past couple of years, this has really just been happening, where you have to get so many credits of educational hours to maintain your licensure as a physician. And one of the issues is the system's in place. It's been rolling for about a year. And these physicians have to get, I think it's 150 credits over 3 years, but there's a really limited number of opportunities for them to be able to get credits right now. So we thought we could fill one of those needs as well. And then perhaps most importantly, we really were kind of trying to capitalize on a resource that was already there by trying to train physicians that were already working in these positions, just trying to give them this extra skill, and then trying to work with this equipment that, for the most part, is there. The sustainability of that is a whole other issue, but regardless, we are kind of starting with something that we felt like we were just capitalizing on an already present resource. So then we moved into how do we do this? We sort of made up a justification for this is why we think ultrasound fits really well here. Point of care ultrasound specifically for physicians. And we in our organization just kind of discussed all this and started getting ready to present an idea to the Ministry of Health. We had contacted the Ministry of Health, and we basically said, you know, we think this is a good idea. We've found value in this in our practice. We've talked to the physicians that work for you, and they think it's a good idea too. Do you want us to teach ultrasound? And they're like, yeah, train everyone, start tomorrow. And we're like, no. So this kind of started this whole year-and-a-half-long negotiation process of how do we best do this. Because ultimately, we all shared the idea that we're really working for Rwanda. We want to make sure that any program that we're doing fits with their national strategic plans and is really ultimately directed by what they want to get out of it. We just sort of offer our experiences and expertise to help guide them in decisions. One thing we did insist upon is that this initial training is on a small scale, that it's really like a pilot level program, because we didn't want to create this whole big program and institute something within their healthcare system and then find out that it completely doesn't work, that point of care ultrasound really doesn't fit in Rwanda. And they were amenable to that. Over the course of all this back and forth, we had multiple miscommunications, usually involving us thinking we could work at a particular hospital, and then when we would prepare all of our plans for that, they'd be like, what are you talking about? You're not working there, you're working here. And we would start over. But ultimately, we settled on a plan where we would take a couple physicians from each of the 5 different provincial district hospitals in Rwanda. The provincial hospitals are kind of like the shining stars of the district hospital system. And we would put them through this training course that I'll get into a little bit more, and then gather our information from the results of this course for design of further programs. And the minister was okay with that, and we went with that plan, and that's kind of what we've stuck with throughout the time. We tried to make sure that we were communicating with other stakeholders as well. The Rwandan Medical Council is somewhat separate from the Ministry of Health and is responsible really for the licensing of physicians and whatnot, and kind of take hold of the CPD aspect of things. We were working with them. And ultimately had some other partners that I'll get into a little bit more. But so that continued the Ministry of Health. Other sort of organizational issues that we dealt with is we wanted to try and be like really legitimate in terms of being an organization and in terms of being able to get some good funds for running this program as well. So we're really, really fortunate to be able to connect with some University of Pennsylvania law students who helped us through the whole 501c3 nonprofit registration process, which we're recognized as a 501c3 now, and it's an atrocious looking process that I fortunately don't know a lot about because they handled it all. But it was really great. We created a website and we started working on fundraising. We didn't have a particularly coordinated strategy. We were just kind of all looking for different grants and putting out applications whenever we thought there might be something of value, set up a credit card donation portal, hit up our family and friends, and tried to have discussions with Ultrasound Manufacturing Corporation about, you know, you invest in education now, you're building a market for yourself later. So with limited success in all of those areas, we were able to win one grant from someone called the International Foundation, and we're still sort of having some discussions with different manufacturing corporations. Different in-country things came up, the various authorizations from the different stakeholders that we ended up connecting with became somewhat of a bureaucratic nightmare at times, but ultimately it all worked out in the end. And then another big question, which still sort of remains a question, is the sustainability of the equipment that we're dealing with. This donated stuff is not of always the best quality, and sometimes even if it is in new quality, it's older models of things that aren't necessarily supported, and it never really comes with a service contract to get support from the manufacturer. So we were hoping that support for something like that would come through a connection with a manufacturing corporation. And then our other idea for support of that is through Do So in Engineering World Health, that we're running a biomedical engineering technician training program in Rwanda, of which ultrasound repair and maintenance is incorporated. And there's nothing sort of concrete worked out in that way. This is just sort of our answer to some sustainability questions. Another big question, and one of the reasons we insisted on this pilot small-scale approach initially, is who knows if point-of-care ultrasound is really the right solution in Rwanda? These doctors are really, really busy, and everyone's going to tell us that they're going to do it. Of course they are. They know that's what we want to hear, and I'm sure they do want to do it. But it's a reality even in our emergency departments here, that given the option of sending a patient over to radiology to get it done while you go do something else versus doing it yourself, often you pick sending to radiology. They don't always have that option, but regardless, I think it's a very legitimate question of whether point-of-care physician-performed ultrasound is really the answer. We also wanted to try and get something started to be set up in terms of who's really going to take this over when we, as the foreigners with Pure, make our exit. Our goal in Rwanda is to put ourselves out of business. We ultimately want to transition this into a train-the-trainers program so that all of this can be locally held and administrated. and we're not sure exactly how that's going to materialize yet. Certainly, just running the pilot program, we're in the early stages. But we started to have discussions about the idea of forming kind of an ultrasound education-based consortium of different institutions, all of these different stakeholders in Rwanda that are interested in promoting ultrasound education through various disciplines. Physicians, technologists, nursing has come up. There's a need for more radiologists, clearly. Training on that level is an option. So we've been having talks with the Kigali Health Institute, the National University of Rwanda, and then there's a Rwanda Society of Ultrasound amongst the radiologists there as well. So all of that led up to this summer when I got to go back to Rwanda as part of the Global Health Fellowship here, but then also kind of getting the logistical things all sorted out for Pure as well. And we hit this major snap in that part of the discussions we've been having with the Ministry of Health have been, she really wants this to be a diploma-level program, which is legitimate. A diploma-level program is the first academic credential at which physicians are recognized for a higher pay level. It's more prestigious. It's a bigger level of education than sort of the CPD certificate level that we were proposing. She had asked that we be sort of vetted by the Senate of the National University, and that meeting was supposed to happen in July. Of course, the agenda was full. It got pushed back. We had already booked all these trainers to come to Rwanda in September, as we've been planning. So we hit this real impasse of, what do we do? Do we just push forward, or do we kind of try and hang back and put our plans on hold? And we changed our strategy up a little bit, and we kind of pushed forward a little bit and just said, this is what we have to offer. If we don't start in September, then some of these resources that we can offer will be lost in the form of these trainers that were already planned to come over. And ultimately, it worked. And everyone received it well. I think part of the reason why we're able to push it through is that this being a CPD offering has turned out to be huge. I was at a CPD conference this summer, and they were telling us that we're one of only 4 programs that actually have a program that physicians can enroll in to earn these CPD credits. And they were very happy with sort of our very thorough approach to the different assessments that we're going to deliver, the sort of very organized and well-stated presentation of our curriculum, and so on and so forth. So I think that really kind of helped us move through as well. So there were some more logistical things. Yeah?
Who are your trainers? Did you get to train?
So the trainers they're all part of Pure ultimately, but they're mostly drawn from emergency medicine physicians. We tried to focus primarily on faculty level emergency medicine physicians who have had ultrasound fellowship training or significant ultrasound experience on their own. We do have some senior residents going as well, but they're really coming from all over. One of the things we try and be at Pure is very multi-institutional. We're really not confined to any particular site, location, city, what have you. So people are coming from all over. There's a radiologist coming from Sweden back in November, I think is when he's going. Yeah, I think most people are Americans otherwise, and there's a couple radiologists, but mostly American emergency medicine physicians now. So everything kind of moved forward, and now I'll just kind of go through the training course as it's been unrolling. This is the advertisement that we put out to all of the potential trainees in Rwanda. It was circulated by the hospital directors at the 5 hospitals where we were recruiting trainees from. And then it was circulated on a general list of physicians as well. We ultimately had 48 applications from these 5 different hospital sites. We had a Google form for the application, which was amazing. They filled it all online. It all came out in the database for us, and it's a fantastic free tool if you guys ever need something like that. We ended up talking with the hospital directors to see how many they could allow. Every hospital allowed 4 trainees to go off for the training, except for one that said only 2 could go. And then we tried to choose amongst them. We had a lot of discussions amongst our primary group of Pure. We talked with some different Rwandan physicians that might have some perspective on people on a more personal level. And we tried to select people based on the level of interest that they demonstrated in their application or that we knew of personally. We tried to give preference to general practitioners because the physicians that are more specialized in OB, surgery, and whatnot are not going to be able to use the kind of wider breadth of the curriculum. We tried to focus on people who are at an earlier stage in their career, as there was some skepticism from our Rwandan colleagues that some of the people who were applying who've been doing this for 20, 25 years were actually just trying to get their CPD credits out of the way. And a few people, it was more of a political decision than anything. Ultimately, 17 trainees showed up to start the course, and they all finished the course as well. We had 6 trainers come in for this course, so we had a pretty good ratio of trainers to trainees, and we ended up being able to borrow some ultrasound machines from Mindray, an ultrasound company, and then Philips Healthcare as well. And we had 6 machines total, so one for each of the trainers to use. And we had this great little classroom up there to use. The training was based out of DGHI, which is the primary teaching hospital in the middle of Kigali. There was a nice central location. So the training itself was a combination of PowerPoint lectures, hands-on practice on each other. They would take the machines out to the ward. But the real emphasis we tried to put was on the hands-on practice and having the trainer there to be able to sort of direct them and so on. They ended up spending a total of 8 days at DGHI doing this intro training course, and then at the end of the exam period, at the end of that 8th day, they went back home to their home hospitals, and one of the trainers went with each group of them to the 5 different hospitals. This is to make sure that they were comfortable performing ultrasounds on their own equipment, and that they felt comfortable with the procedures for data collection and so on. We just kind of tried to identify any sort of problems. These are just some pictures from the course and from the follow-up period of different physicians performing ultrasounds and instruction going on and so on. So we have a number of different assessments for this training course. These are examples of some of the sort of general ultrasound-based knowledge examination that we gave. We delivered this examination prior to them completing the course, and then after as well, to assess that they had improved and gained knowledge appropriately. And I've heard that all of them have. I don't know the data to present yet. We just finished the course last week. But this examination also is going to be given to the trainees at monthly intervals. because part of, and I should have explained this during the slide where I was showing the advertisement for the training, but the overall structure of training is a 2-week-long introductory course initially, followed by a 5-month-long follow-up period. And the follow-up period, there's not really active education going on as much as every 2 to 4 weeks, one of the trainers shows up at their hospital and just sort of checks in and makes sure that they feel comfortable with things, makes sure that they've been actually scanning appropriately, reinforces different curricular elements. And on a monthly basis, we're going to evaluate them again through this test, make sure that they just have the baseline knowledge. And then we also have a survey tool to try and assess just sort of their impressions of ultrasound and what they report in terms of the number of ultrasounds that they're doing. This is actually an example of some questions from our baseline survey that we did, and this was completed by all of the trainees before the start of the intro course to just try and assess sort of like where their head's at so far in terms of ultrasound. And then these are some questions from the follow-up assessment, where it's not as much to gather this baseline information as to just sort of check up and make sure that they're making appropriate progress and see kind of what their impressions are with the training as it goes along. Another examination we're doing is practical examination, because you can know everything you want about ultrasound. If you can't handle a probe and interpret images, you're kind of worthless. So we have this OSCE, observed structured clinical exam that we've designed, and this OSCE was required of them before they could move past this introductory course into the follow-up period, and this also will be re-administered on a monthly basis. And part of the reason we're doing this so frequently is that we're really trying to identify the best way to do this ultrasound training in this kind of setting. There's a real paucity of literature about how to do ultrasound training like this. There's a ton of anecdotal reports of, I went to Kenya for 2 weeks and did ultrasound training, and I think it was great. But there's not a lot of sort of systematic, this is what we found, this is how much time it took, and so on. So we're really trying to address that with our different assessments. We are having them complete a data collection sheet for every ultrasound that they do. They don't have to complete everything on there. This actually incorporates the different data points from the different exams. So if they do a biliary exam, they have to answer the specific question. And then we have another little section at the end just to have them comment on how the ultrasound might have changed their management, if it changed their management. And this is something that we want them to do for every single scan. It's all de-identified. Ultimately, we're keeping it in a database to keep track of their personal sort of scan totals, as we have a requirement that they each have to complete 25 ultrasound scans in each of these different categories in order to pass the course in the end over this 5-month period. But we're asking them to personally keep track of the patients that they scanned, of some sort of identifying information, so that they can do some chart-based follow-up later on to kind of see if they did change their management based on ultrasound, if we can sort of extrapolate some information and report on some cases where maybe it did change the patient outcome as well. On the Dropbox thing, we wanted to create a system so that if they're doing scans and they're doing an ultrasound and they find something and they're just really not sure, they feel like they need some help interpreting it, we set up this Dropbox and we're staffing it so that someone is responsible to check it at least once every 24 hours, and then they'll review these images. And these are people that are checking it are our trainers as well, all ultrasound trained physicians or radiologists. And that we promise we'll get back to them within 24 hours with an email, kind of helping guide them. And there's a little map of the different hospital sites, just kind of showing you where they're at. There's really 2 of them in the center there in Kigali. And the furthest hospital up there in the left-hand corner is like a 2.5–3 hour drive from Kigali, but the other ones are a little bit closer. It's not too far distance-wise. But the trainers, when they go for their follow-up visits, they go to Rwanda for about 2 weeks, and they're expected to go hit all of these 5 hospitals for a couple of days each, just checking with the training. So that's our pilot programs. And like I said, it's ongoing. We just finished the introductory course, and our first set of follow-up trainers are in Rwanda now. They've hit a couple of the hospitals so far, and everything's going really well. I mean, as to be expected, there's some misunderstandings here and there, but everything's getting clarified. I think that our very close contact model that we've kind of set up with the frequent follow-ups is working so far in terms of being able to correct any misinformation early and try and improve the quality of the data we're going to collect ultimately too. So in the future, obviously we conclude this pilot, we analyze it, we want to write up and publish what we can from it. And then we want to continue talking with the different stakeholders I was mentioning in regards to the idea of an ultrasound education-focused consortium within Rwanda. And then we want to continue discussions with different potential ultrasound corporations who might be able to provide some financial backing and may be interested in a partnership. Sometimes these corporations will have resources in the way of people who can provide ultrasound training. Certainly there's equipment potential, but so we're going to continue some conversations with that. And we've got a fairly promising one going on right now, so fingers crossed. Ultimately, too, we need to decide, assuming the pilot worked or even didn't work, because if it didn't work, we're not planning to leave Rwanda. We just need to change directions and figure out what really is the best strategy for ultrasound education in Rwanda. So obviously, this diploma program has been a priority of the Ministry of Health, and multiple people have mentioned it as something they're interested in. There's the option of just providing more CBD level courses. And then there's the potential of taking these initial set of trainees and the ones that were just real rock stars and really interested in learning more ultrasound, putting them through some extra education to start the whole train the trainers aspect of this. And these are some more pictures of ultrasound scanning and the course and the follow-up. And that's it. So. That's our website. If you're interested in checking it out, please feel free to email me, or if you have any questions now or after, I'm happy to stay and talk.
Seems to be a really awesome investment, moving the trainers to the home sites after they've completed the 2 weeks. And then you said every 2 or 3 weeks there's another follow-up visit to the location?
Yeah, the way we envisioned it being structured, it's changed a little bit just on the practicalities of who was available, was that for the first 2 months of that follow-up period, a trainer would visit every 2 weeks to these hospital sites. I think we're going to be able to maintain that for the first 2 months, maybe with one exception. And then for the final 2 months, we slow down to just once-a-month visits, and then the final examinations and assessments are going to take place in February 2013.
So then are those trainers living in Rwanda?
No.
They're just flying every 2 weeks or 3 weeks?
Yeah, and that model was decided upon primarily because we really wanted to be able to offer high-quality trainers. Because really, I mean, we're not paying any of these people. These people are actually all fantastic, dedicated volunteers that are offering to pay for their own plane tickets, like on the promise that, we're trying, like, we'll try and get more money so that we can fund that. We do have enough money that we're paying for their hotel and transportation expenses in country, but they're paying sometimes as much as $2,000 for their plane ticket to go there and using their vacation time from work in order to go there as well. So we've been really lucky to find people who have a level of expertise where we know that the quality of the education that we're giving isn't going to be compromised by inexperience of the educators. And we just think that that'll ultimately help with sort of the data we're trying to collect on the success of this program. That won't necessarily be a confounder with all of that. And then also, we just want to offer the best that we can sort of deal. So this comes at the cost of an enormously higher cost with all of these flights back and forth, but it's really the only way you can get these kind of people to go over there. Even 2 weeks is a stretch sort of thing. Did you have a question?
I actually have the same question.
Okay, cool.
Yeah. It was very interesting, very good presentation. I'm an OBGYN and we both do ultrasound training
Cool.
in obstetrics. And I wanted to know, I know Partners in Health also has done quite a bit of ultrasound training in Rwanda and published in that area. What's the relationship between the trainers they procure and Partners in Health and some of the providers that were there already?
So the work she's referring to with Partners in Health, unless you know something that I don't do.
No, I know they also have a really nice open access online ultrasound journal as well that is
and like the ultrasound in
it's like a how-to step-by-step ultrasound.
Yeah.
Our manual.
Yeah, that free book is great. So there's an emergency medicine physician who works for PIH named Cecilia Shaw, and back in, I think it was 2007, 2008, she did kind of a similar project with the Partners in Health physicians only, and she ran them through a course, and she followed them up. She was actually on site during that time, and she published a couple papers that basically said at the end of the training course, we had success. They felt comfortable using ultrasound, they were using it frequently, and then she followed them up, I think it was at 9 weeks, and said, we still have success. They're still scanning, they're still passing their exams, they're doing great. And so really that work was kind of the inspiration for Pure in a way too. That was, when I was doing this Google search, that was part of what I found and how I initially connected with one of the people that mentored her through that process as well. So one of our rationales for doing it this way too is that PIH is like its own little special world. Everything is a lot better in the PIH setting than it tends to be in the standard district hospital setting in Rwanda. So we were concerned that she had great success, but could we reproduce that success in a more sort of typical district hospital setting in Rwanda? That was part of what we were doing there. And she's been fantastic. We've been, I mean, like I said, one of our primary founders of Pure and one of our board members is one of the people that mentored her through that process. And Cecilia herself has been just great in advising us in different ways, but we're not directly working with Partners in Health in any official way, which is kind of an informal relationship. But yeah, their work is really kind of the basis for a lot of this.
Their work too showed a significant portion of the ultrasound work in the obstetric patient population.
Say that again?
They had a large number of scans that were primarily for obstetric.
Yeah.
Either pregnant women with pregnancy situations. Are they getting, the trainees, are they getting OB ultrasound training as well in the emergency setting?
Yeah, and so that's part of our curriculum. I didn't talk a lot about the specific curriculum because I thought it might just take a little too long and it was a little difficult to present concisely. But we've tried to create sort of a hybrid emergency medicine curriculum. The way we use ultrasound in the emergency department here and by the American College of Emergency Physician guidelines, which is also really supported by the British College of Emergency Physician guidelines as well, is in a very specific, goal-directed, answer a clinical question way. And so for pregnancy in particular, first trimester pregnancy is sort of the main indication. All you really care about is whether this pregnancy is in the uterus or whether it's not. But that's not good enough in the setting of Rwanda, where they are doing all of the obstetrical care sort of thing as general practitioners. And so we tried to flush out the curriculum based on different things that we thought were particularly relevant to their practice, based on this needs assessment that we conducted, surveys we did of potential trainees, just talking to different people involved in educating the different radiologists and so on. And then using like the sheeted manual that you were talking about to kind of guide that as well. So we're doing a more comprehensive obstetrical curriculum than we frankly are for anything else, even though that really doesn't reflect emergency medicine practice with ultrasound at all. But we're doing some limited cardiac scans, the obstetrical scans, the scanning specifically of like the body of the liver and the spleen is not something we do so much in emergency medicine, but it's very relevant in their setting, looking for abscess and masses and so on. We are doing thoracic ultrasound, volume status assessment with the configured beam cable that I was showing you, musculoskeletal, soft tissue ultrasound, renal. Yeah, it's kind of like the emergency medicine curriculum plus is sort of what we designed for it.
I have to say I'm just incredibly impressed by how comprehensive everything is, and you're working with the local partners and the like. You say that you first got interested as a medical student, and now you're through your emergency fellowship and in a global health fellowship. And so I wonder if you could comment a little bit about how long this process has been in evolution, because obviously it's been through many stages. And my other question is in terms of selecting the physician population per se, especially out in the district hospitals. We're actually in the process of trying to implement a similar thing, so I'm trying to learn much from you in terms of handheld echocardiography out in the communities.
Yeah.
Only we're targeting clinical officers and medical officers. So I'm curious as to whether they're a group that could potentially be a target in Rwanda, or it's really much more than physicians.
Well, what are clinical and medical officers specifically?
So clinical officers are much like they're much like your PAs here.
Okay.
Physicians.
Like mid-level providers. Okay, cool.
And medical officers have gone through first year of internship.
Okay. Yeah, so I guess your first question, I don't know, I'm not sure how to answer that. It has just obviously been a long process, and I feel fortunate that I've been able to kind of move through my training and been able to contribute something that I've learned in my training back to this setting that I just kind of care deeply about, and just the idea, I mean, I'm here doing a Global Health Fellowship because I like this stuff, and I think that this is the right thing to do, and I feel personally satisfied by working with people in Rwanda, and I just enjoy it, kind of thing. So yeah, it's great that I've been sort of able to combine my experience with ultrasound and emergency medicine. And
But are we talking 8 years that this has been in formation? 4 years?
No, 2.
Okay.
Yeah, I'm sorry, I should have clarified that at some point. Yeah, this all kind of came to fruition in terms of the idea and sort of genesis of the program in like October of 2010. So it was just about 2 years overall. And your other question, I absolutely think it could be translatable. Are you familiar with a program called Imaging the World?
I have heard of it, yeah.
Yeah, so they work in Uganda, and what Imaging the World is really a cool program where they take these handheld ultrasounds and they train complete lay people, community health workers, to take the ultrasound probe and basically just fan it back and forth and get this movie of ultrasound images. And then this movie is transmitted with a limited amount of clinical information by cell phone, by like text messages, to someone who can help interpret it. And in Uganda, they have a pretty robust ultrasound technologist training program, and these technologists are trained to interpret images as well, so they're taking some of the burden off of the radiologists there. But so basically, they look at the movie, and they look at the clinical indication, and they say, this patient's fine, this patient's not fine, but I'm not sure why they need a better imaging study, or this patient's sick, you need to send them to the hospital right away. And it's sort of used like a triage tool in that way. And I don't remember if they've published anything yet, but they've been really successful. They're primarily radiologists around, and they're looking at potentially expanding elsewhere as well, but they've worked primarily in Uganda. But just based on that, I guess I don't have personal knowledge of a lot of other programs that are similar. There's absolutely no reason you couldn't involve a mid-level provider. The people who are getting training as an ultrasound technologist, they are sometimes coming right out of high school with their first degree and so on. So yeah, I mean, absolutely. Yeah.
Liz, what outcomes are you going to use to define success in clinical treatments?
Well, we're not sure how exactly it's going to direct what we do next, but we're looking specifically to see the number of scans that these physicians are doing, especially longitudinally. That's kind of where I feel like the rubber really hits the road for us, is that we have these surveys, and it's great if people keep telling us that they love ultrasound and they're doing it like gangbusters, but if they're not actually doing it, then what? Then are we really successful? So that's sort of the primary indicator that we want to look at the end of this 5-month training period to see if they're still doing it. But then we also need to look at this longitudinally, really, because we're creating a very false environment in the context of the real world with these trainers showing up every 2 weeks or once a month to be like, hey guys, are you doing your ultrasound? So that's our primary indicator to show that, we think this is successful, because success is going to be defined by their really using it and using it on a high quality level as well. Another sort of thing that we're going to look at research-wise, outcome-wise, is trying to have a radiologist or an ultrasound-trained physician look at these images when they're blinded to other information and just say, was this image of adequate quality that a diagnosis could be made based on it? What is my diagnosis? And try and match up what the trainees put as their diagnosis and whether this is a high-quality imaging study and so on. But we're going to try and take all the information and put it together, but I think those are probably our two biggest outcome measures.
One more comment. That's the most, I think, the toughest question and the most important one for us.
Yeah.
And I know even in obstetrics, we are convinced that it helps reduce maternal morbidity, mortality, neonatal morbidity, mortality, but we have not shown that. And it may, well, true, but we do know things like for ectopic pregnancy, we know clearly it shows a decrease in maternal mortality with maybe early ultrasound diagnosis. But one question came up in one of our national meetings, it could actually have the opposite effect that we expect it to have. And that anecdotally, some patients think that if they've had ultrasound and they've been told everything's fine, they don't need any further prenatal care. And so it may actually not have the effect that we expect it to have in this context. I personally don't think that will be the case, but these are the kinds of questions that certain outcome measures may answer, like, a decrease in let's just say in a hospital for X condition, or a decrease in need for transfusion, some more clinical outcome that you may be able to look at if you have a larger number of people who are scanning for X condition to see whether it really impacts their morbidity.
Yeah, absolutely. And that's really the meat of any of these questions, right? Is, are we really influencing patient outcomes with this? We talk about changes in management, but was it the right change in management based on the scan, like you were saying? It's not something that we're in the position to be able to do. Like, we want to do this pilot study first to get some baseline information to show that we can do this effectively. And then our hope is that with doing this pilot well and showing that we can make something just of the pilot, that would help us in terms of applying for bigger grants and finding other financial factors that could support a larger scalable program that could potentially get at something like morbidity and mortality. And another thing, just kind of along the same lines of what you were mentioning with ultrasound having the opposite effect in terms of changing patient perception about what they need to do with their interaction with the healthcare system. Another thing that was something we thought about in the genesis and design of this program is that when you go and do ultrasound training on a very short term, and you're really not making sure that people really got it and are retaining these skills, you're really being responsible with ultrasound. I mean, ultrasound has a lot of limitations, and a lot of the radiologists that take objection to emergency medicine performed ultrasound would argue that performing and interpreting an ultrasound is the hardest radiology skill to learn. And so who are we to say, oh, we got it in just a few weeks of training and so on. And we have studies to show that, with certain limitations, we can get it. But regardless, it's a very real question, and part of the reason why we're trying to study how do you best do this training? Like, can we be successful? How long do we have to do it for? People will, I've heard it dubbed an ultrasound incidentalloma, because any kind of problem that a patient has, someone will be like, let's give the ultrasound. And ultrasound isn't something you really use in certain conditions, and it's not ideal. You can't image through an air-filled part of the body very well, and so you can get lots of artifacts, and you just really need good training to do this responsibly.
Are they charging for the scans also? Are they signing a commitment not
So
to charge people?
Not yet. I mean, we really don't have a lot of control over that aspect, but we try to emphasize the training that these data collection sheets are not part of the chart, that you can write in your chart sort of your impressions and so on, but the things that we're teaching them to do here, and we're sort of signing off saying like, yeah, you know, you can do a limited cardiac ultrasound successfully, and we'll vouch for that, it's limited. We haven't taught anyone how to do an ultrasound of the pancreas. We really didn't get into ultrasound-guided procedures, all kinds of different stuff like that. We're just trying to emphasize that it's not replacing radiology studies. It's just sort of replacing some of them and adding other tools. Well, thank you.